All right, so when you're thinking about looking at all the problems that women have, it's good to start thinking about where the pain started in the first place. And rather than just thinking about the uterus or endometriosis, it's good to actually think also about the bladder or the bowel. Maybe some vulval pain, or sometimes recurrent thrush or candida can actually irritate and initiate pelvic pain as well. There can also be pelvic infections. When women have had pelvic pain for quite a while, I think we should all expect that there will be a degree of pelvic muscle pain involved as well. If you have a painful back condition, we've all got used to the concept that there might be a back condition, but often the worst pains are actually from the back muscle spasms. And many people with back pain will explain that the spasms are the thing that bothers them the most. The difficult thing for women is that the muscles that are relevant to this area are actually on the inside of the pelvis, so they're not easily seen and they're not easily examined or recognised. So there's two types of muscles that can be involved in this problem. So the pelvic floor is the first one, and if you have a tight or painful pelvic floor muscles, then there can be pain with intercourse, pain with smear tests. Women don't like using tampons because they're uncomfortable, or they can find vaginal examinations particularly painful. There'll often be pain with movement or a general ache, and when the pain gets bad, there'll be stabbing pains, which are sometimes described as a stabbing pain in the centre of their pelvis or up the vagina or up the bowel. There can be difficulty passing urine or emptying the bladder, which is not really surprising because most of us, if we wanted to stop passing urine, we would contract those pelvic floor muscles. So if they're already tight and contracted, it can be difficult to pass urine. And a lot of these pains refer to the lower back. So I often see women who come and they say, my back pain's a problem, but they often think it's related to something else, when actually the pelvic muscles inside are the major problem. Now the other muscles that are often involved are some muscles called obturator internus. And these are muscles most people haven't heard about because they're on the inside of the pelvis. They're on the sides of the pelvis just inside the hip, and they extend out to the leg. So when they go into spasm, many women will find that it's hard to move, it's hard to walk, and you can often pick somebody with these problems from the beginning because they're slow to get up from their chair sometimes, or they're slow to move around, or they find that movement aggravates their pain, or some exercise. So if this type of pain will often be a pain on the side, which can come on suddenly, that might be a stabbing pain, that lasts a while, makes it difficult to move, improves with a heat pack, and a lot of women will find that when they have the spasm in this muscle, they'll prefer to curl up. This type of pain often refers down the front of the leg, not always, but often, and it can go to the back as well. It'll be worse in people who do a lot of core strength or Pilates type exercise because obturator internus is one of the muscles included in the core. So tightening and strengthening these muscles can often aggravate that type of pain. It can be worse with prolonged sitting or prolonged standing. It's often movement related. Once again, there can be pain with a vaginal examination, and there can be pain with a vaginal ultrasound, especially when the probe pushes out on the sides of the pelvis. The next thing to realise is that if there's been pain on most days for more than 3 to 6 months, then there will be changes in the nerve pathways. There aren't blood tests or scans you can do for this, but anybody who has a pain for more than 3 to 6 months on most days will have changes in the nerve pathways that make everything more sensitised and make managing the pain more difficult. So if you have somebody who finds that the area on the pelvis, abdomen is sensitive and things, then I think it's really worthwhile managing these nerve pathways. The thing about nerve pathways is that once they're sensitised, often women feel really bad as well. So it's not just the pain, it's actually the feeling bad. And that's where the fatigue, the low mood, the anxiety, poor sleep, nausea, dizzy, faint and sweating comes in. Sometimes there'll be a burning pain, although this is less common. Now, I think that anybody who's got long-term pain realises that it's had an effect on their life. Growing up with pain is never good. But once the nerve pathways and some of the brain pathways and things change, it really is, there is more to pain than just the things we've described here. Pain becomes an emotional experience, which is understandable for anybody with pain. People worry, they're fearful of what it will do to their work or their lifestyle, their relationships and things, and they tend to withdraw from social activities, finding that sometimes it's just easier to stay home. This, of course, doesn't help, because when they do stay home, they've got nothing much to think about apart from their pain. But it's so common for people to find that they're reducing their activity and they're choosing to rest more, which is also bad for pelvic muscle pain. Now, getting better, because really, although you've taken quite a while to become unwell, there is lots that can be done to look at this whole situation. The management plan for persistent pelvic pain, well, it's stop the problem that started it in the first place, manage that, reduce the muscle spasm, manage the nerve pathways, and then get back into life and get more active and more involved with things. So, looking at the pain that started it all. With periods, we've already spoken about periods and how you can minimise this. And for most women with endometriosis and pain, minimising the periods is actually essential. It's going to be hard to manage the other things if every month you've still got bad period pain that aggravates everything. Endometriosis, yes, you can have a laparoscopy to excise that, but I think that it's worthwhile realising when you've had enough laparoscopies. Unfortunately, it's often that when women have pain, they end up having several laparoscopies and looking for that fix that they hope will fix the whole situation. Laparoscopies are useful, they're a wonderful tool for removing endometriosis, but I think that they aren't the only tool. And if you've had more than 1 or 2 laparoscopies, I think that it is time to first look at all the other things you can do that don't involve surgery, rather than having more surgery. Managing the bladder and the bowel, the vulva and the candida, and of course any pelvic infections if they're present, although these are less common, is all very important. So manage the pain that started it all. So, period pain, as few and as light periods as possible until you're ready to have a baby, and laparoscopy only if there's a good reason to think that that's actually going to be beneficial. And that's usually for people that have actual period pain over several days and leading up to a period. It's often not the first choice for someone who has long-term persistent pain on most days. For bladder overactivity, there are diet triggers, and a medication called amitriptyline is often useful. I recommend that quite a lot in the patients that I see, just in small doses, and about half the women find that it's very useful and half of them find that it doesn't suit them, in which case there are other options. For an irritable bowel or bloating or food intolerance, consider a low FODMAP diet, and there's details for all of this at the Pelvic Pain Foundation website. Reducing pelvic muscle spasm. This is usually the sort of pain, if you've had a flare of pain or a sudden really bad pain, think pelvic muscle spasm first. It's often the cause. If I come into work on it after a weekend and hear that one of my patients has been in a casualty department or emergency, often it's the pelvic muscle spasm that actually sent them there. It was the severe pain that they worried about. Unfortunately, casualty departments aren't always great at sorting this out, and I think there's many things you can do yourself to help this problem. So, for pelvic muscle spasm, it's worthwhile stopping the aggravating factors. So, once again, manage the periods, the bladder. Reducing core strength exercise but keeping moving is excellent. So, these days, a lot of young women really aim to build up their core. And for some, that'll be fine. But for women with persistent pelvic pain, it often just aggravates the problem. It's good to keep moving. So, resting is not going to improve this pain. But do it gently and regularly. The sort of exercise that's good is exercise that doesn't hurt, with a lot of different activities away from the core. So walking doesn't usually cause a problem. And if, for example, you were thinking of dancing or something, then things like ballet that have a rigid stance are bad, but things like salsa, which have a lot of movements away from the core, are much better. Sort of things that have lots of different movements and are good for your health rather than, straining muscles that are tight and things. There are pelvic muscle stretches that you can do, which those of you who do yoga might recognise on the Pelvic Pain Foundation website. You can download a pelvic muscle relaxation CD that explains how to relax a lot of muscles from the link here, and that's a great thing that you can do. There's a longer version to help you learn the techniques, and a short version you can do every day, whatever you're doing, to help you just keep some of those muscles relaxed. Pelvic physiotherapy is a wonderful treatment for this, but you need to be seeing a pelvic physiotherapist that understands down training of muscles. If it's someone that's trying to strengthen the pelvic muscles, then, or it's stuff that hurts you when you do it, you may not be quite at the right person. And unfortunately, this expertise is a bit hard to find, but a pelvic physio that understands this is wonderful. For the most severe pelvic muscle spasm, I use injections of botulinum toxin there, which might be a surprise to many women. But just as it stops women frowning when it's injected in the muscles of their face, it can stop those muscles cramping, at least for a while it's working. It's not a permanent fix, but it can also help reduce the spasm for a while to help them get on with all the other things to improve the whole picture. Treating the nerve pathways. This is really important, and it's a lot of women feel uncomfortable with a type of pain you can't see. They've quite understandably worried that people didn't believe they had pain. They absolutely have pain, but it's not all pain you can see. So realise that the nerve pathways are very important. Keeping active with things you enjoy or value is a fantastic way of keeping motivated and active. So sometimes I hear people say, I think I'll give up work and just get better. Unfortunately, often they don't get better. They stay at home and they focus more on their pain. Often, although being overtired and overstressed is not helpful, it's good to keep active and keep moving. Exercise is excellent, but you just have to pace it and just start small and do it regularly. Having a regular lifestyle with regular sleep patterns is also very important. When nerves are tired, they're more irritable and they transmit pain more. And then there are medications that help reduce the sensitivity of the nerve pathways. These aren't painkillers. They're actually things that you take every day that reduce the sensitivity of some of those pathways. And the ones that I tend to use are the amitriptyline, which is very good for overall pain, for sleep, for an overactive bladder, for background headaches, for an irritable bowel, for bloating. It doesn't suit everybody, but it's often a really good first choice. It's cheap and easy, and your doctor can help you. Next one I often suggest, which is completely different, is one called duloxetine. Now, duloxetine has activity for anxiety and low mood, but it also helps pain pathways. So this one might suit people who are feeling very anxious or low and have pain. And often when we're tense or anxious, we actually hold our muscles quite tight, so that can often improve that type of pain as well. There's other, from a completely different class of medications, there's pregabalin or gabapentin. And if you do have pain on most days, often the opportunity to see a pain specialist who actually understands about all these medications can be really valuable. One thing I would say is that many women who have severe pain unfortunately begin to use regular opioid medications or some stronger pain tablets. And while they can be useful for very short terms, unfortunately, if they're used for longer term or used regularly, they do actually overall tend to increase pain and make the pain pathways more sensitive. So if you are able to avoid using these regularly, that's really beneficial. Getting back into life. None of the pains that you have are likely to be dangerous. So reducing fear is actually really important. And there are ways of managing these problems. So you don't have to be scared. It's good to keep active. You have far better things to do with your life than to think about pain. It's good to learn more about the pelvic pain that you have and the Pelvic Pain Foundation has resources and information to help you. It's good to keep active, keep working or keep involved with your family or keep involved in volunteer things, at least part-time. And remember to pace your activity, because if you do too much one day, you might fall in a heap the next day. Just do it regularly and gradually. Many people say, but can't I just have an operation? Can't I just have a hysterectomy or whatever and it'll all be over? Well, the answer is unfortunately no. And I have another video here to play. Now this one, I'll just explain. This one was in a young woman. She was just a teenager. Here we go, it's all right. There we go. She was only 15 when I did this one. And if you look down here, there's endometriosis right across the pelvis. From the left side we're looking at now, the little clear lesions. Right across, there's speckledness all over the side wall of the pelvis. Little specks of little blood vessels and clear lesions and abnormalities. She's only 15. And across here, all that area of skin there, that's the rectum there, but all the other area of skin has got endometriosis. And there's black bits and white bits and red bits and clear bits. So this is a very significant area of endometriosis. Now in a minute you'll see that I've actually removed all the endometriosis. I've taken off all the peritoneum, that skin that's affected, and the new skin will grow over in a couple of weeks' time. So this doesn't look great at the moment. It will look beautiful afterwards, but all her endometriosis has been removed, absolutely all of it. The ovaries have been lifted up with a little dissolvable stitch that will just keep them up for a little while and then break so they don't stick and things. So that's just a temporary thing. But you can see that everything's been removed. So the issue afterwards, is that enough? She's 15, is that enough to fix her pain? I don't think so. She has far more than just endometriosis. She needs to minimise her periods so that she can reduce the chance of new endometriosis lesions and having continued pain. So we put a Mirena intrauterine device in, even though she was only young, and we've suppressed her cycle with the contraceptive pill so that she has no periods. We managed the constipation that she has, because you don't need that if you've got pelvic pain. So she takes Normacol Plus, which is the one I prefer because it gives you nice soft bowels without too much wind. She had an achy pain on most days with the stabbing pain, so she had the pelvic muscle pain. You can't see it at a laparoscopy, but it's there. So she does regular gentle exercise, she started the stretches, and she saw a pelvic physiotherapist to help her get back moving again. She had a bit of an overactive bladder and headaches, so she takes a little bit of amitriptyline each evening to keep them under control. And she was missing school, life had become difficult, she was very anxious and very unsure of herself. Happily, 3 years later, she's actually fine with no particular pain conditions. We'll have to keep an eye on her over time, but can you see that laparoscopy alone was important, but not the only management of her pain and would not have been enough by itself. Now this is the slide from the Pelvic Pain Foundation of Australia, and I hope that you will look at the website. You can join the Facebook to find out what's new on pelvic pain and look at the resources. We're a not-for-profit organisation in Australia, and we look after teens, women and men with pelvic pain. This is the website with lots of information and events and things that people can become involved in. And there's a free pelvic pain e-booklet that you can download and send to you or any friends of yours that you choose to. And just to say that most of us think this is just a women's problem, but men have pelvic pain too. They get everything women get without the periods, the endometriosis and the migraines. And they're often this is even more hidden. So thank you very much for listening today.